It's a real pleasure to get the chance to talk to you guys. I'm also in the Division of Epidemiology at Vanderbilt, and I was the Director of Graduate Studies for the Epidemiology PhD program here for about 5 years. So, you know, I've had a foot in both puddles for quite a long time. And so, you know, you guys are kind of my other tribe. And today I'm going to kind of focus on, I sort of had to, you know, make some decisions because as Ryan mentioned, my research kind of is relatively diffuse, I guess, and unfocused is another way to describe it. I do lots of things with lots of different outcomes. But today I'm going to focus on some of the cardiovascular traits that I work with and really as they, you know, the through line that connects all these different studies are polygenic scores for blood pressure. So I started getting interested in blood pressure early on as a faculty member. And, you know, obviously the reason why we're interested in blood pressure and the genetics of blood pressure is because hypertension is, you know, a risk factor for many other really significant health outcomes. And, you know, according to some people's estimation is the, you know, the leading cause of morbidity and mortality in the world. And, you know, there are some really significant public health impacts of hypertension in the United States. You know, according to the CDC, 47% of American adults have high blood pressure. And, you know, a minority of those actually achieve control of their hypertension with medications or lifestyle changes. And in 2019, we had over 500,000 deaths that were attributed, at least in part, to hypertension. And this just costs the United States, you know, over $100 billion a year. You know, it's just a really significant problem. So even if you can make a small difference in the risk profiles associated with hypertension, you can make a big difference in absolute terms, you know, with regard to morbidity and mortality. And this problem persists across the entire world. These are just statistics from the United States. So on a global scale, this is really a significant problem. So when you look at kind of where hypertension is, right, in the United States, you know, where we are in Tennessee and where you guys are in Alabama are hotspots. And, you know, in part, this is because of the demographic distribution of people in the United States, right, where the states with higher percentages of recent African ancestry populations tend to have higher hypertension rates. And one of the reasons for this is because there's this really profound disparity in hypertension prevalence and severity between recent African ancestry and, say, European ancestry populations. And so this is an element of the public health problem that, you know, that we face, especially in this part of the country. And, you know, I've got this heat map from the CDC, but then I also, just to kind of start to tie in the studies that we started doing with these, I'm showing a map of the recruitment for the Million Veteran Program. I'll talk about that in a minute, just to show you kind of, we have pretty good coverage of where, you know, blood pressure, high blood pressure and hypertension is a significant public health issue. So I'm a genetic epidemiologist, right? I do genetic studies of traits with epidemiological methodology for the most part. And, you know, blood pressure traits are a good target for these kinds of studies because they're known to be heritable. There have been studies since the 60s in humans and model organisms that have shown heritability of blood pressure traits. And many, many studies of blood pressure genetics have been performed using GWAS and other methodologies. The GWAS catalog, I think 77 studies exist with blood pressure as one of the target traits in those studies. And thousands, literally thousands of independent loci have been conclusively associated with blood pressure traits, over the long history of genetic studies of blood pressure. So, the Million Veteran Program, that I've worked with, and also the BioView resource at Vanderbilt, which is resources that are essentially electronic health records linked to genetic data. And you guys have resources like this at UAB. Those electronic health record data are, of course, not designed to be used for research. And so when you're going to, conduct a study, the way I tend to think about it is, what elements of the data in the electronic health record should I, abstract or use to create what I would have if I had done a cohort study, right? If I had actually recruited patients and, conducted an epidemiological study design. And so, typically when we're looking at blood pressure data in a cohort study, like a prospective cohort like the UK Biobank or some others, you would have some eligibility criteria, and then you would measure blood pressure in like a controlled environment with the person sitting down, and you might take multiple measures and record those and use the average of those measures over some period of time at enrollment, right? So you'd have kind of baseline measurements of a trait like blood pressure. But obviously in an electronic health record, that's not what's available to you, right? You might have dozens or hundreds or even thousands of measurements from a given individual. And so we had to devise a strategy for how to decide which measures of blood pressure we would use, or whether we use some kind of central tendency or average or something like that. Ultimately, we decided we wanted to use like a specific measurement of blood pressure that had really been taken in an individual rather than a summary of many measures. And the reason for that was that measurement has occurred at a specific point in time. So we can write down an age, and we can write down what medications they might have been on at that time. And so in the Million Veteran Program, and this is similar to the data that are in BioView, we observed that we had over 220 measures per person on average. And, what we decided to do was use the first median eligible systolic blood pressure and the corresponding diastolic blood pressure. What does that mean? So, a median, right? It's you might have multiple observations of the median value. So we would take the one that was first in temporally in the medical record. And by eligible, I mean that we looked at all the measures in the medical record, and we would remove any that had been measured in the emergency department, in an inpatient setting, or any measure that occurred at or after some ICD-9 codes or 10 codes that indicated specific diseases that we thought would, dominate the measurement at that time, such as chronic kidney disease, secondary hypertension and heart failure. Or if we had a pain score, when we didn't for all the measures by any means, if that score was greater than or equal to 5, we would censor that measure. So what remained after kind of blocking out all those measurements was, the eligible measures, and then we take the first median from that. And then if we had prescriptions for antihypertensive drugs prior to that measure, we would just add set constants of millimeters of mercury to the systolic and diastolic respectively. And I know like that's not ideal. We did this because it's according to the analysis protocol from the charge cohorts, and it allowed us to be more comparable in, say, a meta-analysis. And I'll be talking a little bit about those in a minute. And then for pulse pressure, we just took those, systolic and diastolic measures after, adjusting them for the antihypertensive drugs, and, took the difference. So we did a little bit of, evaluation in the BioView data just to sort of try to decide whether or not this was a reasonable approach. And when we did this, we had the benefit of working with Chenyu Liu, and we who had access to, raw data from quite a few different cohorts. And here what you see is the measured blood pressure, systolic blood pressure, both from the raw value and the adjusted value after accounting for antihypertensive medications on the right, and in bins of ages, right? So 20 to 80 years old, and BioView are the red crosses in these figures. And you can see, in general, we plotted inside the cloud for multiple prospective cohort studies with blood pressure measured at baseline. So ERIC, probably many of you are familiar with, Health ABC, MESA, the Women's Health Initiative, et cetera. And so, this suggested to us that what we had done with our choice of measurements was reasonable. And when we just took random measures, it didn't really look like this. It was much higher. It was much more variable, and we weren't always kind of in the cloud of all the other measures. And when we looked at diastolic blood pressure, we saw a similar kind of a behavior, although the distribution was a bit wider amongst the studies, so it was easier to be in the cloud. But we did like that we saw, an increase of diastolic until, age 50 or so, and then a decrease. And these lines were just me putting that in. That's not like a statistical model fitting, kind of a representation. I just wanted to draw your eye to where the BioView measures were. And, this occurs because diastolic blood pressure responds to blood vessel elasticity, and that tends to diminish after age 50, and then you start to see lower diastolic and higher systolic blood pressures after that age. And which is what we saw in the data, which we thought was a good sign. So, this is kind of the in the past part of the talk, but after we developed kind of this approach and we're working with the MVP, we did a GWAS, and we did it in collaboration with the ICBP, the International Consortium for Blood Pressure, and I'll talk more about them at the end of the presentation. And we took some data from MVP and the UK Biobank, and we put it all together in a GWAS, and we detected a bunch of independent loci that were definitively associated with blood pressure traits. And we did some conditional analysis and a bunch of other analyses. And I'm not going to talk about all of this, but just to point out that we did this GWAS with a relatively large sample size at the time of several 100,000 individuals. And this was all published in Nature Genetics in 2019. And in this study, we had these three main outcomes: systolic, diastolic, and pulse pressure. And we just did linear regression, adjusting for kind of standard covariates. And then we just did a meta-analysis, as is quite often done in GWAS consortia. And then we did some secondary analyses with PHEWAS and TWAS modalities. And, I'm just showing you these to kind of illustrate that we had pretty good statistical power, right, to detect loci, but also to point out that we didn't end up explaining a ton of variance in these traits. So we had, 340 loci were detected for systolic blood pressure, and 124 of them were novel. And you can see the effect sizes that we were detecting were maybe better expressed in micrometers instead of millimeters, because they're very subtle, like smaller than you could ever measure with a with a sphygmomanometer. And the same was true for diastolic blood pressure, albeit we didn't find as many novel things, and pulse pressure. So you know, in this study, we did take our sentinel loci, our primary loci that we discovered, and just did a crude genetic risk score where we just took a linear combination of the regression weights from the GWAS and the genotypes that we observed, and we just created simple scores using the sentinel SNPs or the genome-wide significant SNPs from the GWAS. And when we did that, and we did a PHEWAS in the remainder of the Million Veteran Program data, we detected hypertension, right, with a p-value that was infinitesimally small. Heart and renal disease, kidney disease, all these circulatory system phenotypes came up, along with things like renal failures and kidney disease and a little bit of diabetes and whatnot, which are known to contribute to higher blood pressure. And that was our systolic blood pressure, diastolic blood pressure. The genetic risk scores gave us very similar kinds of results. The one thing I think that is hard to see on this plot that we saw in that paper that we thought was pretty cool was aortic aneurysm showed up in diastolic blood pressure, and that sort of confirmed a prior observation in the Lancet in like a systematic review and meta-analysis that diastolic blood pressure was a predictor of aortic aneurysm risk. And, we thought that was cool. And pulse pressure, kind of more of the same. And all this is in that paper if you wanted to go back and see it. So, that was 2019, and we finished that work, and, we're, I guess, pleased with ourselves that we had gotten a paper into a good journal, and we collaborated with the big consortia. But, even during that project and afterward, we were trying to think about, how can we leverage these data and these results to provide some insights into, some of the consequences of hypertension or traits that are related to hypertension that perhaps are more difficult to study, than blood pressure, right? So blood pressure measurements are kind of everywhere. They're easy to do. They don't take a long time. They're not real expensive. Everybody has a blood pressure. And so sample sizes, can get pretty big, as I'll show you towards the end of the talk. But other, traits that are related to blood pressure perhaps are not so easy to study. And so, one of these that, we had been thinking about, for a long time is preeclampsia. So preeclampsia, probably many of you know this, but it's a complication of pregnancy, and it's characterized by hypertension after 20 weeks. It affects a pretty large percentage of pregnancies, and there's this pretty remarkable disparity in preeclampsia prevalence. And the prevalence of preeclampsia has been increasing, we think, likely because of the obesity epidemic in America, but in general, it's definitely going up. And preeclampsia causes all kinds of horrible things to happen. And I have this list here, but, stillbirths and growth restrictions, birth weight restrictions, preterm birth, and all these things that are very bad, can arise in preeclamptic pregnancies, as well as observations that preeclamptic women are more likely to ultimately die from cardiovascular disease, and that children of preeclamptic moms are more likely to have hypertension and high BMI later in life. So, here's this significant public health problem, and, it's very difficult, it's relatively difficult to study compared with something like blood pressure. So, if we could leverage our discoveries in blood pressure to provide some insights into the nature of preeclampsia, maybe that could be worthwhile. Oops, I'm going the wrong way. Okay, so with that goal in mind, we went back to the GWAS results from the Geary et al. Paper, and we said, okay, let's develop a polygenic risk score for blood pressure traits, so systolic and diastolic and pulse pressure, And, you know, at the time, this was a while back, we used, you know, fairly primitive methods, the pruning and threshold method of PRS development, where basically you have the GWAS data and you account for the linkage disequilibrium or the correlation between nearby variants in those data. And you want to set a low threshold, meaning that when you pick SNPs to go into your model, that they're statistically independent of one another. We also impose like a physical distance limitation on that. And then you sort of iteratively scan over the data. You have like your training data, which are your summary statistics. Then you have like a target data set, which are individual level data where you've got like the trait you're interested in and the SNP data. And you scan over p-value thresholds from the summary data to decide, you know, where's your sweet spot where you explain the most variance in your target data. All right. So when we did that using the BioView resource, which is just another genetic data linked to electronic health records resource at Vanderbilt, we had quite a large sample size to work with, over 37,000 people. And, you know, we got very, very small p-values and were satisfied that these models were, you know, capturing variance in the explaining variance in these blood pressure traits pretty well. And the effects I'm going to present are per standard deviation of the polygenic risk scores that we derived from this process. We had participants that we found from Emerge. This is a network that UAB is a part of. BioView and the Penn Medicine Biobank. All of these individuals had a documented pregnancy or delivery in their electronic health records. They were between the ages of 18 and 44. We did restrict in this case to non-Hispanic white or non-Hispanic black because of the very small numbers of individuals that we found in the other race groups, and this was still a little preliminary. Of course, they had to have genotype information available, and they had to be diagnosed with a preeclampsia code for cases. And we did go and look with a chart review, and we found that these codes actually have pretty good PPV, around 0.9. So here's just some quick characteristics of who we included in the preeclampsia study. You can see our total number of cases were about 1,300 with about 7,500 controls. And, you know, I think we had relatively similar, you know, BMIs and ages amongst these various participants from the different sites. All right, so results. So when we go and look at these, you know, polygenic scores for blood pressure traits, what we see is that they are associated with preeclampsia risk. So, and these models were adjusted for age and age squared, BMI, race when it's the transethnic, and let's see, and yeah, I think that's everything. And you can see, you know, all three of these polygenic scores ended up being associated with, you know, preeclampsia risk, which suggests, right, that our initial thinking perhaps was reasonable, that, you know, we can leverage these large scale studies that were done in, you know, hundreds of thousands or maybe over 1 million individuals to learn something new about the nature of these, you know, other phenomena, these other, you know, health events that might be very difficult to study using genome-wide association studies and whatnot. And, you know, I think before we saw these results, we could have argued to ourselves that, you know, preeclampsia could be its own entity, right? It could be its own outcome with distinct genetic causes. And perhaps it isn't closely related to, you know, essential hypertension, you know, and its genetic risk profile, but this perhaps suggests that they do share at least some, in part, some genetic risk factors. And this is just kind of the same results again, but I split out the black and white participants, and you can see, you know, we have fairly similar effect sizes, except for the diastolic blood pressure didn't really give much signal in the Black participants. So, you know, we were excited about those results. You know, we were looking at that and thinking about other cohorts and other resources that we had access to. And another study that I'm involved with at Vanderbilt is a study of congenital heart defects. And this is another really significant issue in public health. You know, there's millions of people in the United States who live with congenital heart defects, and it affects around 1% of all US births, which is about 40,000 per year in the United States. And the prevalence of congenital heart defects is increasing, and you know, I don't know if that's just we're better at detecting them and characterizing them, or if there's an actual phenomenon that's causing, you know, congenital heart defects to become more common. You know, these defects can occur in virtually any structure of the heart. You know, the septum, which is like this tissue that separates, you know, the chambers, the valves, which are up here, you know, these guys right here, you know, they control which direction the blood can flow through the heart. And then chambers, you know, there are things that can go wrong with these chambers. So, you know, our study captures all of those things. Oops, did I? You know, and this is, you know, something that people have been thinking about, especially in the pediatric cardiology space for quite a long time, and many advancements have been made, especially in surgical techniques to repair these defects. And but nonetheless, you know, they are definitely related to fetal and child and deaths during childhood, and they remain the main cause of cardiac arrest in young people. And there's this large inter-individual variability in outcomes where, you know, the surgeons have devised scores to decide, you know, basically, you know, how much danger they think a patient is in, you know, how complex their procedure is, and that explains to some extent differences in outcomes, but there's still quite a lot of mystery, I think, in, you know, who survives and who recovers well from, you know, surgical repair of congenital heart defects. So, of course, you know, we're not the only people who are thinking about using polygenic scores in difficult to study populations that are derived from, you know, large scale studies of adults. And, you know, while we were thinking about what to do in our congenital heart defect population, which isn't huge, this paper came out, and we were really interested to read this. And so this paper basically is a paper that was published that looked at polygenic scores for blood pressure traits in premature infants that were born at very low birth weights. So like these kids are born at like less than 3 pounds or so of body weight. So really small, really, you know, really early. And what they observed in this paper was that increasing burdens of blood pressure, increasing alleles, right? So alleles that would confer increased risk of hypertension in adults, for instance, were protective against death in these premature infants, okay? And this does kind of make intuitive sense, because one of the big issues in these infants is, you know, they just can't keep their blood pressure up, and their organs don't get sufficiently perfused with oxygenated blood, and they experience organ failure, and you know, that's often the reason why they pass away. And, you know, they get treated with vasopressive, you know, blood pressure increasing treatments to try to keep their blood pressure on target. But it turns out that if you have a genetic tendency toward, you know, higher blood pressure as an adult, you don't need as much treatment, and you tend to live more often than a comparable infant who was born preterm, low birth weight, who doesn't have those alleles. So we have the precision medicine and pediatric cardiology cohort at Vanderbilt. This cohort was collected by my colleague Brent Kanankerl there, who's a pediatric cardiologist and surgeon. And it's a prospective observational cohort, which is comprised of individuals who are experiencing their first surgery for these heart defects at our children's hospital. And they've been recruiting for quite a long time. The subjects in this study were recruited through 2018, although recruitment is ongoing. We have about 2,500 people in this study with genome-wide association study data. And so, we get data from their electronic health records. And also there's a little bit of survey data from the parents. And then we also get blood from these individuals that we use to do genotyping. So here's just some characteristics of the participants that we used in this study. As you can see, they are majority white. We do have some African ancestry participants. And just to walk you through a little bit here, the data we used in this, you can see that these children are typically pretty young, maybe a little over 6 months. And the vast majority of them are within 1 year or 1 year or younger in age. The older children in this study, there's just a few of them. And so you can also see that we've measured the stat category. This was a covariate in our models, and it basically just measures the surgeon's estimate of how likely a patient is to survive the procedure. And then the vasoactive inotropic score is basically a dose equivalency of blood pressure increasing medications. And I'll give you a little more detail about that in a minute. So when we calculated our polygenic scores and looked at the relationship with various parameters associated with recovery and survival from the surgical repair of congenital heart defects, what we saw was that virtually always the diastolic and not the systolic blood pressure polygenic score was associated with mortality, how long they were in the ICU, and even to some extent their vasoactive inotropic score, where people with higher polygenic scores, meaning that they carry more alleles that increase blood pressure as adults, require less support to achieve target blood pressures after surgery. So we thought, oh, this is cool, right? So we write a paper and submit it to a journal, and the reviewers were like, all right, you need to show me a little more than that. And so we went back and forth a bit, and ultimately they helped us reach this point where we were able to show that there's actually an interaction between the vasoactive inotropic score and the diastolic blood pressure polygenic score, such that here you have these tertiles of the inotropic score, right? And tertile 3 are the kids who got the most treatment, right? Who needed the most support. The tertile 1 is the lowest level of support, and then tertile 2, it's not on here because it's easier to visualize this way, but it just lies kind of between these two. And when we look at the probability of in-hospital mortality with regard to these parameters, what we see is that actually these kids who are receiving the most support, and they tend to have like the worst stat categories and things like that, their survival has a strong dependency with their diastolic blood pressure polygenic score, where if their score is higher, their survival is virtually indistinguishable with the patients who are getting the lowest level of support, who tend to do the best and stay in the hospital for the least amount of time. And you know, this is kind of the first thing that I think anybody's seen that determines, you know, that differentiates between, you know, who is getting, you know, these kids who are getting the most support and whether or not they survive, which of course in our mind is similar to the results reported by Gopal et al. And suggests perhaps an evolutionary origin of hypertension that may be related to robustness or resistance to preterm birth and injury, but that's speculative, right? But yeah, so this paper just came out in Circulation Research, and it's just another example of, you know, like looking at a population where we would never achieve the sample sizes necessary to build polygenic scores for blood pressure, really, you know, in congenital heart defect kids, nor I think would we think to do so with blood pressure polygenic scores in that population. But we can leverage these polygenic scores that have been derived from large-scale studies to look at research questions like that. So here's another example of this kind of an idea where, you know, as I mentioned earlier in my talk, you know, a substantial proportion of people with hypertension fail to achieve control of their blood pressure using medication or lifestyle, but predominantly medication. And, you know, these people are called apparent treatment-resistant hypertension, right? And it's a real serious problem because people with this who can't achieve adequate control of their blood pressure are just at extremely high risk of, you know, ischemic stroke and heart disease and all these other outcomes that befall, you know, people with uncontrolled hypertension. And so we decided to take a look at this with regard to polygenic scores for blood pressure. You know, and so we had a pretty straightforward design where in our controls, they needed to have a hypertension diagnosis, treatment with 1 or 2 antihypertensive drugs, and BP measures, you know, that were within a reasonable range, less than, you know, the hypertensive thresholds at the time when we did this. They've changed a bit since then. For 3 months following the initiation of their last antihypertensive medication. Of course, we can do this kind of thing because we're looking at electronic health records, right? We have these like nice, dense, you know, temporally oriented observations over a long period of time. And then in our cases, we followed a pretty standard definition where they had to have failure to achieve the controlled blood pressure on 3 antihypertensive drugs, including a diuretic, or 4 or more medications, regardless of whether or not they achieve control. And this is kind of a standard way of classifying treatment-resistant hypertension. And then we just totally excluded people with late-stage kidney disease or you know, obvious causes of secondary hypertension. So, you know, we used the Geary et al. Summary statistics again. We also combined that with the Liang et al. From the Cogent BP study of African ancestry individuals, and Biobank Japan, just to try to get, we were sort of experimenting to try to get a large, you know, multi-ethnic polygenic score. And we used a little bit different methodology this time. We used a newer method called PRS CS, which uses like Bayesian approaches to shrink the effect sizes based on the observations of linkage disequilibrium in the regions around the sentinel SNPs. And then we did a little bit of p-value thresholding as well, which I might talk about in a minute if I have time. And we found that p-value thresholds less than 1, so like 0.0, you know, 5 times 10 to the -3 or something, you know, tend to explain more variance than just the raw output from PRS CS, which is not how the authors of PRS CS recommend you use their method, but we've seen that this is pretty consistently true. And then our target data for this polygenic score development was the UK Biobank participants, excluding the overlap with the Gary et al. Study, which I mentioned we used some of those data there, but there were about 340,000 that weren't part of that study. And of course, we achieved like infinitesimally small p-values for our polygenic scores. So we were persuaded that they were working well. So we had our apparent treatment-resistant hypertension outcome and some covariates, and we modeled this using logistic regression. We had a transethnic population in BioView. We also looked at our non-Hispanic white and non-Hispanic black subsets, and these effects are presented per standard deviation of the polygenic score. We also did a little bit of predictive modeling here, where we modeled both polygenic scores, age, H-squared, sex, body mass index, and smoking status, which is derived from the electronic health records. It's not a perfect, assessment. It's not as good as what you would obtain from a survey, but it does tend to associate with everything in the expected direction. And the average estimated glomerular filtration rate per individual across their records. We used tenfold cross-validation to mitigate overfitting, and then we just looked at C statistics and Breyer scores for discrimination and calibration respectively. So here's what those results look like. We didn't detect anything in the non-Hispanic black population, not with statistical significance. In the non-Hispanic white, we did see polygenic scores for systolic blood pressure, and the combined model with both were associated with treatment-resistant hypertension and in the transethnic as well. And our C statistics are just a little bit under 0.7 with Breyer scores that suggest that we have reasonably good calibration of these models. And so again, and this paper just is in press at circulation, genomes and stuff. This again points to the idea that treatment-resistant hypertension is hard to study. Ryan and I have been involved in some of those analyses before, and you're just not going to achieve the kind of sample sizes in a trait like that. That's hard to classify and involves a subset of the population as you are in a trait like blood pressure. And if they share some kind of etiological factors, then you can predict or detect relationships between the genetic causes of blood pressure and treatment-resistant hypertension. And prior to doing this, again, we sort of didn't know whether or not we would see a relationship, because treatment-resistant hypertension could be its own entity, right? It could be more related to drug metabolism and issues like that than it is hypertension per se. But it seems to be they at least share in part some causes. So I'll just go through quickly some new studies. These are things that are currently under review. And you can find these manuscripts that describe this next two projects in the Research Square website. This one is from Hellwedge et al. And so this is a large-scale GWAS in African ancestry populations. In this case, we took the MVP data and the Cogent BP study. Cogent BP was published for African ancestry blood pressure. So, they had about this sample size. So we're about quadrupling that sample size in both across both stages in this study. And here's just a little diagram of all the stuff we did. I'm not going to talk about all of it, but we did a discovery GWAS. We had some replication resources. And then, of course, we developed some polygenic scores, and I'm going to talk about those results. In this study, we detected, quite a few significant loci, with some novelty amongst these. And we did some DEPICT and GWAS and some other analyses. And you can see this is what our Manhattan's plots look like. I'll just go through these quickly because it's not material to the results. And then, of course, we wanted to optimize our polygenic scores. So these were PRS CS scores, and we found, that we did a little p-value thresholding and got better performance from thresholds other than the 1 threshold. And, and then looking across deciles of the polygenic scores for odds ratio of hypertension, we could see that, a pretty linear relationship. When we predicted hypertension using these polygenic scores and independent resources, we got a polygenic scores, age squared, BMI, and principal components of ancestry. We got an AUC of about 0.7, and we also saw differences in the mean systolic blood pressure of about 7 millimeters of mercury and diastolic of about 5. We also did a large-scale study of blood pressure in the International Consortium of Blood Pressure, and this included the UK Biobank, the ICBP data, and the MVP, as well as BioView. We had about 1 million individuals across 4 data sets, and that analysis, everybody had been analyzed using the same basic analysis strategy with linear regression. You can see a little bit of our QC, looking at our lambda statistics for, inflation. And, this is pretty much all just due to polygenicity, because the LD score regression intercepts for these were like right around 1.06 or 1.08. And these are the black are all, right? So you can see, lots and lots of signals. The novel signals are not nearly as statistically significant as the rest, right? Because we're the largest study, so we're detecting subtle effects. And you can see we're just kind of like lowering where we're looking at the effect size versus the minor allele frequency. We're just kind of like lowering the bar down here and detecting ever more subtle effects. So we're just adding SNPs to the list of SNPs that were already known with this analysis. So here's what these Manhattan plots look like. You can see, very small p-values, right, throughout the genome. Blood pressure is a highly polygenic, extremely complex, genetic architecture, kind of a phenotype. We detected a few novel SNPs. This really wasn't the main take home from this study in the manuscript that's available here on Research Square. This is Keaton et al. But when we took these data and we developed several genomic risk scores just using sentinel SNPs and a polygenic risk score using a pruning and thresholding method, you can see we explained like 7% of the variance in systolic and almost 8% in diastolic. And if you remember earlier in the talk, we were getting like maybe half that in our study from Gary et al. From like 3 years ago. So, there is some progress in that regard. And when we looked at, variance explained across p-value thresholds, again, we found kind of an optimum around 0.01 for all 3 traits. And this is just looking at the average, and this is in the Lifelines cohort. So these are in independent data from those in which we used to do our polygenic score development. And you can see, we had like about a 13 different millimeter of mercury difference in systolic blood pressure, which is a huge difference, more than you would expect to achieve with most drugs. And, about a 9 millimeter of mercury difference in diastolic blood pressure. When we combine the 2 terms in a model, the odds ratio for the deciles, you're at about a 5 or 5.5 odds ratio of hypertension in the European ancestry, but when we bring that over to African ancestry, we see, a much more subtle association across the deciles with the polygenic scores. So they don't transfer that well to other ancestral groups, it seems, but they are very strong in the target population. And so when we look at this polygenic score with, age squared, sex, BMI, and principal components of ancestry, we see areas under the curve of around 0.8 and a very subtle improvement with the addition of the polygenic scores. So these scores don't really seem to help, but they don't add a huge amount of discrimination to the model. Age is actually the thing that gives you the vast majority of the predictive power there. And this is just a little more that we did in Emerge, where we were looking at polygenic scores from blood pressure, GWAS, and looking at them with regard to hypertension risk. And, we were able to show by adding phi codes to our model, and we used an elastic net to select phi codes and estimate weights. And we did a temporally oriented PHEWAS where, we only included phi codes that were diagnosed prior to the diagnosis of hypertension. And we achieved areas under the curve close to 0.9 using that approach. So, we think that polygenic scores really aren't the answer for prediction in this case, but, there is the ability, we do have the ability to derive foreknowledge of these outcomes using electronic health record data. And the polygenic scores definitely give you some additional predictive power, just not a tremendous amount more. So in this case, it was like 1%. Okay, and I think I've got like a few minutes left for questions. So I have many collaborators and lots of different funding sources that contributed to this work.